Okay, hello everybody. Today we will talk about heart failure and we will start our discussion with a case study. So, we have a 48-year-old man who came to your office complaining of shortness of breath for 2 months. First, it occurred only occasionally following climbing the stairs, but recently it started to occur more frequently, especially when he lay on the bed, and last night he had an episode that awakened him in the midnight. His past medical history is significant for hypertension for 5 years. On examination, you heard a third sound just at the end of diastole, and you noticed an ankle edema. What is the most likely diagnosis? Now, the reason why I put this question here is to tell you that heart failure is actually a clinical problem, and this means that you have to be able to diagnose it from the history and examination of the patient before you order your tests. Now, what's heart failure? Heart failure is actually a state in which the heart is no longer able to pump adequate amounts of blood to meet the body needs. Now, how we do calculate the amount the amount of blood the heart pumps? This is actually represented by the cardiac output, and the cardiac output is obtained by multiplying the heart rate by the stroke volume. So, to calculate the cardiac output, we have now two factors: the heart rate and the stroke volume. The stroke volume is actually dependent on three main factors, and these are the contractility, the preload, and afterload. So we have four factors that determine the cardiac output, and those are the heart rate, the contractility, the preload, and afterload. Anything that alters these factors can cause heart failure, and actually any heart disease can eventuate with heart failure. So, poor contractility, increased preload, increased afterload, and abnormal heart rate or rhythm can lead to heart failure. These are the main four mechanisms by which any disease can end with heart failure. So now we'll discuss some of the mechanisms by which different heart diseases end with heart failure. In myocardial infarction, there is a poorly contracting segment, that is the infarcted segment. This segment will not only stop contracting, but it will alter the contraction of the neighboring segments. It will alter their contraction relaxation pattern, so the contraction of the heart will be disorganized, and this signifies the heart failure. Cases of increased preload, this results in a volume overload. More blood is reaching the heart, and chronically this results in eccentric hypertrophy. And eccentric hypertrophy is actually a compensatory mechanism by which the heart tries to compensate for this volume overload. In eccentric hypertrophy, new smooth muscle cells are added next to each other. This will result in dilated ventricles. The wall thickness remains the same, but the diameter of the cardiac chamber gets enlarged, and this dilated heart will contract poorly, and this results in systolic dysfunction. We will come to the discussion of systolic and diastolic dysfunction a little bit later. And in increased afterload, this causes pressure overload. The heart is pumping the blood against a high amount of resistance, and that is the pressure overload. This will result in concentric hypertrophy. Concentric hypertrophy is the compensatory mechanisms by which the heart try to compensate for the increase in the afterload and the increase in the resistance. And in this case, the new smooth muscle cells are added parallel to each other, not next to each other. And you can imagine that this will result in an increased thickness of the wall and decreased in the chamber diameter, and this results in non-compliant ventricles, and that is the ventricles cannot change their volume when the blood is reaching them from the atria. Now that the compliance is the change in the volume for the change in the pressure. Whenever the pressure changes, the volume of the chamber must change, and this will be disordered in the case of concentric dilatation and pressure overload, and this will result in diastolic dysfunction. This means the heart is unable to be filled with the blood. Arrhythmias are abnormal heart rhythm When the rate of the heart becomes too rapid, this will decrease the filling phase of the cardiac cycle, that is the diastole, and thus the amount of blood that will reach the heart is reduced. So the amount of blood that will be pumped out of the heart will also be reduced. Now, heart failure is sometimes classified into systolic dysfunction and diastolic dysfunction. In systolic dysfunction, the heart is unable to pump the blood, and this results in a reduced ejection fraction. Whereas in diastolic dysfunction, the heart becomes stiff, non-compliant, as we said earlier. This affects the filling of the ventricles. The ejection fraction is also often preserved. That is because the ejection fraction is the result of the division of the stroke volume by the end diastolic volume. So when the end diastolic volume is small, in this case, because the ventricles cannot be filled, the stroke volume will also be small. Thus, the ejection fraction remains the same, and we will discuss this later. This is actually seen in restrictive and hypertrophic cardiomyopathy, and this is the mechanism by which these diseases can lead to heart failure. Now, when there is heart failure, as we said, there is decreased cardiac output, and this will activate many compensatory mechanisms in the body trying to compensate for this reduced cardiac output. And the two main compensatory mechanisms we are going to discuss are the increased sympathetic activity and the activation of the renin-angiotensin-aldosterone system. Now, first, these two mechanisms try to compensate, try to increase the perfusion pressure in many tissues. But on a chronic basis, these mechanisms will actually result in deterioration in cardiac function, because the increased sympathetic activity will be activated when there is reduced cardiac output. The sympathetic system will be activating so that to increase the heart rate and to increase the stroke volume by increasing the contractility. When we increase the heart rate and stroke volume, we will actually increasing the cardiac output. This is how we compensate. But on a chronic basis, you know that the increased sympathetic activity will also result in widespread vasoconstriction, and vasoconstriction means increased resistance, and that means increased afterload, so this will result in deterioration in cardiac function. The renin-angiotensin-aldosterone system is activated when there is reduced renal perfusion, that is, the blood is not reaching the kidneys, and this occurs in heart failure because of the decreased cardiac output. Not enough blood is pumped out of the heart to reach the kidneys, and also because of the increased sympathetic activity. When there is reduced renal perfusion, the renin will be secreted from the cells of the macula densa in the kidney. The renin will activate a plasma protein called angiotensinogen into angiotensin 1. Angiotensin 1 circulates throughout the circulatory system, and when it reaches the lungs, it will be activated into angiotensin 2 by angiotensin converting enzyme. Angiotensin 2 is responsible for many effects that will deteriorate the cardiac function. First, it is a potent vasoconstrictor, and that means it will increase the afterload. And second, it will result in increased aldosterone secretion from the adrenal glands, and aldosterone will act to increase sodium and water retention. It will act on the collecting ducts of the kidney to increase sodium and water retention, and this will result in a volume overload. So these mechanisms are actually responsible for the deterioration of cardiac function over time, and understanding them is important to understand the treatment of heart failure. Now, let's start our medical talk about heart failure. What are the signs and symptoms of heart failure and how they develop? Most of the signs and symptoms of heart failure are actually attributable to a build-up of pressure. When the blood is not pumped from the heart, it will stay in the heart, and it will increase the pressure of the cardiac chambers, and this increase of the pressure will be reflected into both the pulmonary and the systemic circulation. So when there is left heart failure, mainly the left side of the heart is failing to pump the blood, this buildup of pressure will be reflected to the pulmonary circuit, and this will give the patients the symptoms of dyspnea, orthopnea, that is dyspnea when lying flat, paroxysmal nocturnal dyspnea. Also on examination, rails will be heard on the lung fields. When the right side of the heart is failing to pump the blood, the increase in the pressure in the right side chambers will be reflected into the systemic veins, the superior and inferior vena cava. So the patient will be presented with an elevated JVP. There will be hepatic congestion. There will be ascites, edema. All these are attributable to the buildup of a back-up pressure throughout the cardiac chambers and into the pulmonary and systemic circulation. But you also know that these compensatory mechanisms we have discussed are also responsible for these symptoms, and that's why we may see an overlap in symptoms. Edema may be present in patient with left side heart failure, because edema not only results from a build-up of a backup pressure into the systemic veins, but also from the increased water and sodium retention that result from the activation of the renin-angiotensin aldosterone system.